Looks like we made it over here to this session. It was a brief jaunt between rooms, so welcome, Claire, welcome, Opal, to this session and to all of our attendees. We're going to close our conference with the final session that's going to be focused on a core pillar, that your provider strategy and how it contributes to long-term success. So Opal and Claire, in this session, what they will be sharing with us is how to design a 5-year provider strategy that aligns recruitment and retention with operational goals. This session will walk through a step-by-step framework that ensures your medical staff planning is sustainable, strategic, and rooted in your community's long-term needs. So let's begin. I'm going to hand it over to you all.
Thanks, Amy. Well, welcome everyone. We're so glad for you guys to join us here for our last session of our Critical Access Hospital Conference. Happy to be with you guys over the past few weeks and hope that you guys have been getting value from all the rest of the sessions. So I'm Opal Greenway. I lead our provider advisory team at Stroudwater and have been with the firm. I'm in my 11th year and have been leading this team since 2017, but I have been working with providers on their strategy for about 15 years now. And I am joined by Claire Kelly, who has been working with me for nearly a decade as well, who has been doing a lot in the provider strategy space and marrying that up with the other strategic planning work that she does and getting to know providers very, very well and how they impact our success as critical access hospitals. So with that, before we dive into our full session, what we want to do is always get a baseline understanding of what people understand about the topic. So talking about medical staff development plans, we want to know what you guys understand as a medical staff development plan and what it is. If it's part of your community health needs assessment, whether or not it's something that shows the current supply and demand for providers in the community, if it's something that you utilize to outline which specialties you're specifically going to recruit for the next 5 years, or all of the above. So you should see the poll question now. We'll let it go for a few more seconds while people are answering. Right now, it looks like we have 90% of people are saying it's all of the above. Some people are utilizing it for their recruitment plan, 5-year recruitment plan. And then we have, it looks like a few people who are utilizing it as their community health needs assessment or just calculating the supply and demand for the providers in the community. So with that, we'll go ahead and dive into our session and talk about overall, let's just talk about why do these matter, right? Why does a medical staff development plan even matter for critical access hospitals and overall rural hospitals? Well, one thing we know in rural is that it's incredibly difficult to recruit. And part of that is very much driven by the fact that we have a huge physician shortage here in the United States. We're expecting to have at least a shortage of 86,000 physicians by 2036. We went through a pandemic. We have people retiring at an increasing rate, providers who are burnt out, who are leaving the active practice of patient care in their medicine and then switching into other roles, whether it's more administrative roles, teaching, consulting. There's other organizations that are now competing for our providers, whether or not it's technology companies or other endeavors. And so that shortage is going to be hitting us particularly badly. And in rural, it's significantly more exacerbated than it is for the rest of the United States. And so realistically, rural areas really have to be proactive about thinking about their provider strategy, their medical staff development plan. Who are they going to recruit? Engaging with providers as to what their needs are, what are the referrals that are going out of the area, what is the local care that we're not able to keep because we don't have those providers, how are we going to address access and wait times, making sure we service our patients and making sure that they don't have to receive care elsewhere. And it's really important to thinking about it from our financial sustainability as an organization, because when we lose a provider, especially unexpectedly, knowing that it takes 18 to 24 months to recruit a provider means that is significant lost revenue for our organization if we can't absorb those patients elsewhere. So it's really important to be on top of your medical staff development plan to understand really what do you guys need. And really, I mean, I'm one of those people who I think always be recruiting, right? Always think about what are the providers that you need and be proactive in looking for them. But it's important to know, since we have limited amount of money for those investments, where should we focus them? Right. So we're going to be getting into that. When we think about this presentation overall, some of the things that we're going to be going over, making sure you guys understand what's the difference between a medical staff development plan and an overall comprehensive provider strategy. They're not the same thing. And one of them is far more comprehensive. Some of them you might need to be able to update more frequently versus a larger provider strategy. How do you think about it from your long-term goals? Part of that will be addressing your recruitment strategy. How do you address your current staffing needs about, hey, here's where we have a shortage now, we've lost somebody is retired, or we're growing in this area, and thinking about what are the future healthcare demands of your community and how you're going to meet them. Are you going to be meeting them with physicians or advanced practice providers? What is the appropriate way to be able to um, stack those in a way that's financially sustainable for your organization? A key component of that is going to be, how do you engage with providers? What about what their needs are, what their roles are in actually participating in the strategy, and especially if there's operational improvements you need to make to help support that provider recruitment strategy. Lastly, we want to, as we're going through this, we're going to be providing case studies, talking about organizations that we've worked with in implementing a provider strategy, where we've actually helped them with improving operational processes to help make sure that they can attract potential recruitments, and actually be able to improve retention, and how have they been able to use these for long-term success. So with that, we will go ahead and start diving into our presentation. And I'll have Claire go ahead and start talking about the differences between a unique components of medical staff development plan versus a provider strategy.
Thanks, Opal. So briefly going to go over what makes a medical staff development plan a bit different than a provider strategy and the individual components of each and how that kind of comprises both of them. Before we jump in, I'd love to get polling question number 2 going, which is really how old is your most recent medical staff development plan? Do you even have a medical staff development plan that's in place? Is it 3+ years old? Is it 1 to 3 years? Is it less than a year? That's great information to have. So an understanding of how many folks out there actually even have a medical staff development plan in place. So far from the responses that we're seeing, about 50% don't have a medical staff development plan active in place at this point in time. So we'll give folks about 10 more seconds. We'll cue the Jeopardy song theme music as we move through this polling question. Awesome. Great. And I'll share those results. So about 60% don't currently have a medical staff development plan in place. About 10% of you have a medical staff development plan that's 3+ years old, 15% 1 to 3 years old, and 15% less than a year. So let's talk about medical staff development plans. What should a medical staff development plan really do for your organization? What should it tell you? Very simply and plainly, a medical staff development plan should dictate how many providers, including physicians and APPs, your organization needs within certain specialties within your service area. This is what we call a provider complement. It really outlines the target number of providers per specialty that you need in your service area. It'll look at what your current supply of providers are versus what your future supply of providers. What we mean by future supply is, are there folks who are planning for retirement, folks who are 65+ years of age, who probably will be scaling back in the next 1 to 3 years or potentially retiring? Where are those gaps? How do we address for those future needs within your specialties? So what your medical staff development plan will do is map out what your future kind of supply of providers will look like versus what your target provider complement is and what that gap is. Who do you need to recruit within each specialty? Are there areas where you really need to retain certain providers? And additionally, are there areas for increased alignment or improved operational efficiencies within certain specialties? Additionally, it'll tell you what specialties are important to maintain for your organization. If you're a rural organization, what specialties are core to your market? What do you really need to continue to have? And are there other areas or opportunities to increase access via different specialties that may be sustainable for your organization? Or are there areas that are specialties that aren't really sustainable for your organization moving forward? Getting back to that polling question, how often should you conduct a medical staff development plan? In our experience, we find that medical staff development plans work best when they're done every 2 to 3 years. Even though a medical staff development plan will map maybe 3 to 5 years out, doing one every 2 to 3 years keeps them up to date and keeps them abreast of adverse events that are happening. For example, we don't know what's going to happen in the health industry in the next 6 months, let alone 3 years. What's going to happen in terms of market things that you can't control. COVID is a great example of this. No one really saw COVID coming down the line. Having a plan that you're making strategic decisions off of that's out of touch or out of date with current market events is not effective. So making sure that your plan is up to date on those events is really important. So what are the typical components of a medical staff development plan? What are the analyses that we currently see? Well, a lot of times there's 2 key analyses that are included. The first being provider supply and demand based on population in your service area, and the next being access or wait times to specialists. So the provider supply and demand analysis based on the population of your service area really looks at 3 to 4 different studies. And these studies tell you, okay, based on the population that you have, here's how many physicians that you need per specialty. They don't really include APPs. They're really looking at physician FTEs. So to account for APPs, you as an organization have to convert APP FTEs to physician FTEs. In a rural environment, we know that accounting for APPs is really important when you're factored into a medical staff development plan. So adjusting appropriately for APPs in that provider supply and demand is super important. When looking at access and wait times to specialists, a lot of times what happens here is folks will do something called secret shopper calls, where they will call different clinics and organizations in your service area and pose as a new patient that's looking for a new patient appointment. And they'll try to understand based on the different clinics available, okay, if I wanted a new patient appointment at the women's health clinic, that's a 3-month wait. If I wanted a new patient appointment at the primary care clinic, that's about a 2-week wait. So it gives you an idea of wait times and access to certain specialties. Additionally, they'll also pose as a Medicare patient and a Medicaid patient to understand how having different insurance would affect your ability to get in to see providers. So while these 2 analyses are great starting points, we find that it kind of leaves a lot to be desired in a medical staff development plan, especially because these 2 analyses don't really differentiate between a rural setting and a rural healthcare environment versus an urban healthcare environment. So we find that including 3 additional analyses, the productivity analysis, the revenue analysis, and the provider encounter or throughput analysis really helps delineate, especially for rural hospital organizations, really helps make that medical staff development plan much more rounded. And the example I'll give is this. If you do a provider supply based on population analysis, it could say, hey, based on your population, you need 2 general surgeons and 1 gastroenterologist based on your population. Well, your productivity analysis could say, as a rural hospital, hey, we have 2 general surgeons already, and they're at 90% productivity. They're through the roof in terms of productivity. Well, that could be because you have general surgeons that are covering for the low acuity cases that a gastroenterologist could technically do, but the general surgeons are doing it. So really, you need more general surgeons in your service area than your provider supply as outlined. So the productivity analysis helps bring in a different perspective and a different point of view, especially in rural healthcare, in what providers are needed within what services. Revenue analysis is super helpful because that looks at, okay, what are the core service lines or specialties that your organization provides? What are you going to be known for? What are you doing really well in? Where are there potential gaps in care? That's super helpful to know and to analyze going forward. And then you have your throughput or provider encounter analysis. And this can help look for alignment issues. So paired with the productivity analysis, you can understand, say you're an organization with multiple locations and you have 2 primary care locations, and 1 primary care location has providers who are very productive and have a high amount of throughput, where the other location doesn't have very productive providers and doesn't have and has a lower amount of throughput. So what are the barriers to operational inefficiencies that are going on there? What's the difference between those 2 clinics? How can you address some of those alignment issues? That provider encounter analysis is going to help you kind of figure out what's going on and really drive some of those alignment and improvement opportunities. So these 5
one thing,
analyses.
Claire.
Yeah.
Oh, sorry. One thing I'd add actually also, Claire, is when we think about that revenue analysis, is it really provides a good a component for an organization to understand potential risk, right? We tend to know who are our high performing providers. They're like, okay, they generate a lot of revenue for the organization. But seeing a revenue analysis in the context of a medical staff development plan, where it really outlines, here's the revenue associated with each provider, here is their productivity, but here's also their risk analysis of when may they be retiring? How much do you need to plan for potentially that revenue to go away or to ramp down or to be moving? So for an organization to understand it really from a risk analysis in their medical staff development planning is a critical component that I think some organizations that just rely on the provider needs assessment might miss out on.
That's a great point, Opal. Succession planning and making sure you're appropriately looking at potential ramp up times for new providers is really important. So these 5 analyses encompass what we call the provider needs assessment that informs your provider complement. And this is what really makes up your medical staff development plan. So how does this differ from a provider strategy? Well, your provider strategy has all of those components that a medical staff development plan has, but it goes a step further. From that medical staff development plan and your provider complement through a provider strategy, you can create a 5-year timeline of here are our gaps and what we need in recruitment, and here's how we can go and address them. So it looks at, okay, here's what we need based on core specialties for us. Here are the people we need to recruit in year 1 and year 2 versus year 3 and year 4 and year 5. It's understanding of who you're going to recruit when, and for those recruitments that potentially take longer, sometimes 18 to 24 months for certain specialties, you're able to adequately plan along for succession planning, you're able to adequately plan for those long-term recruitments and focus on those down the line. When you take this 5-year timeline and overlay a compensation strategy on top of it and understand how each of these kind of recruitment initiatives, the retention initiatives, and the alignment initiatives are going to impact really the bottom line and the financials of your organization, it ties into organizational structure. If you're able to incorporate this provider strategy into annual budget, into the organizational structure, it's holding your feet to the fire to really drive some of these initiatives forward. So we highly encourage having a compensation overlay on top of your 5-year estimated timeline because it does create something that's more actionable from an organizational standpoint. Additionally, a detailed plan is such a critical point of a provider strategy. A detailed plan typically takes all of those findings from the 5 different analyses and lists them out and then gives you the recommendation or what that target provider complement for that specialty is. It's a roadmap of how you got from point A to point B, the rationale of getting from point A to point B. And this is super helpful to have when you're trying to have providers get behind certain alignment initiatives and you're wanting to include people on the process. It's super helpful to have if you're part of a large organization, if you have a system partner and you want them to come to the table to understand the things that you need done in your community or need help with in your community. This is the rationale and this is the argument that you can lean on to make the case for some of your strategic initiatives. So in summary, a medical staff development plan looks at your provider supply and demand of the organization, tells you what your current supply is, what your future supply will be based on some of that succession planning that needs to be done. It determines and helps you determine what providers you need to recruit where within what specialty, what providers need to be retained that are really productive providers or might need additional support because they could be facing burnout. It helps you identify where there's room in certain specialties for further alignment and improved operational efficiencies, and incorporates those 5 different analyses that we've talked about, including the additional productivity, throughput, and revenue analyses, and tells you what your target number of providers and FTEs should be within each specialty. The provider strategy takes that medical staff development plan a step further and ties it to your organizational strategy by having an estimated timeline, by employing a compensation strategy on top of that time frame that really allows you to tie it to organizational strategy and drive recruitment forward. It includes operational opportunities as well as barriers to alignment. So because you have this timeline that's been activated and you know who you're recruiting in year 1 and year 2 versus year 3 and year 4, you can turn your attention to some of those alignment opportunities that might be on the back burner because you're trying to recruit individuals. But now that you have a provider strategy in place, you know who you're recruiting, you know the timeline for recruiting them, you can now turn to addressing those barriers in terms of operational efficiencies. Additionally, it can tell you if you're an organization that has multiple locations, it can develop where providers should be in terms of locations. Are the right specialties at the right locations? Do they have the right amount of providers per specialty, per location? It helps you dictate what your overall strategy should be and where you're moving providers. And finally, having that detailed plan, having the rationale for and behind your strategic decisions that you're making is so important, whether you're talking with providers or talking with potential system partners. With that, I'll give it to Opal.
Thanks, Claire. So, Claire's telling us about what is included in a provider strategy. I'm going to talk a little bit about what are the advantages specifically of going through all these steps in your long-term planning and thinking about the importance of your provider strategy. So just starting off with high level, some of the advantages that we see from long-term recruitment is really understanding your workforce out into the future, thinking about it 3 to 5 years in advance allows you to also be nimble to take advantage of certain opportunities, right? You can proactively address with your staff what are the gaps? And we have to be, in our experience, most of the hospitals we work with don't have really good referral data. So it gives you an opportunity to start tracking things that you may not be able to get really good data out of your EHR system of exactly where our patient's going, but you're engaging with your providers specifically about, okay, in the last 3 months, what did you send out? Like, let's really actually look at what referrals did you send out? How are we tracking that? Is that identify some gap in the care, right? As opposed to just, if you just ask a provider once, they're going to think about, what did they have to send out last week? And maybe the specialist in town was unresponsive or is backed up. And so they're like, we might as well go ahead and send you drive 4 hours to go see a specialist in the urban area. It also allows you to think about opportunities where some of the organizations I've worked with have had the extreme benefit of actually being able to recruit retired military field surgeons as their general surgeons, which those people have hands-on experience with a very large scope of general surgery. And so, okay, we had a general surgeon we were planning to recruit for in the next 2 years. And we were hoping if volumes were good, we might be able to have a partial GI surgeon in year 4 of our provider strategy. But here we are, we have found a civilian military surgeon now who actually can do both of those services. And we can get a head start actually on providing certain GI services, get that going at frankly, a lower cost than hiring a whole nother surgeon, maybe supplement an APP in the complement for them in year 3 and see how that's growing, right? What is that ramp up looking like? Are we going to fully be able to service the market appropriately with this? Or do we need to stick with their current plan of, okay, by year 4, we are actually going to have enough volume in general surgery to keep this surgeon so busy that we do need to get a GI surgeon in year 4 and stick to that plan. So having that long-term plan allows you to think about who might be the best candidate that you should recruit for. Is it somebody who has additional scope in their practice, in their years of experience, in their training background, where that you can tap into them? Also, it allows you to think about emerging talent, right? We're not just talking about, okay, who's available in the market right now. You can start thinking about who will be available in the market in the coming years. So in rural, one of the things that we find is that when we look at providers who stay in the area, they're either from the area, they are trained, or they were trained in the area, right? So they need to have some sort of commitment or connection to rural, oftentimes to make it past, just a couple of years or past paying back a student loan program. And so when we can identify people in our community, maybe you find out this person's in medical school or this person, that went to the local high school and now they're in medical school, you can start developing those relationships with individuals who they're not looking for a job yet. They're really just focusing on their residency program. That's future them's problem. But by having that relationship with them, you can go ahead and start engaging with them. And we have organizations that are locking down contracts years in advance with people who are not actually eligible to practice medicine yet, but they may be in their program. But you can at least try to build up the bench that way. Yes, there are risks associated with that. They may not pass their boards. We just had a hospital found out that their OBGYN who they had planned on, who's been working there for a little bit, hasn't passed yet. Okay, but they have, you can plan around that. And that still is a much more secure provider than trying to go out and thinking you're going to get somebody in the next 3 to 6 months. Pre-pandemic, I could get primary care in 240 days or less, and especially if this was 300 days. That was my average, but it was still under a year. If I need to start recruiting for next year, I just think about that this year instead of thinking 3 to 5 years out. Now, post pandemic, we are seeing primary care is over 360 days and it's over 400 days for specialists. When we're looking that far out, we definitely need to be tapping into like who's coming up, who's an emerging talent that we might be able to have, and we have to be thinking longer term because that provider may not be available to us for quite a while. Another thing is when we look at it, you can really create a win-win situation for both the organization and for the providers that you're potentially recruiting. When you're thinking about it long term, especially if you're going and talking to people who are in residency currently, somebody if you have a residency rotation at your hospital or nearby that that you're connected with or affiliated with an academic as a tertiary that you're working with, you can find out who their students are and actually provide them a clear career path, giving them that job security, even in this market where people think, oh, providers hold all the cards, they can go wherever they want. There is still, when especially providers now who are sitting on mounting student loans, they want some security. They want to know that they have a clear path because then they can focus on their training. They can focus on passing their boards, right? So that job security and knowing that, especially if it's a hospital that is eligible to help them with their student loan repayments, definitely get like it creates that strong connection with them. Also, knowing that you're proactive, we have seen providers be very positive about management and the leadership of a hospital when they are proactive instead of having to be reactive constantly as to, oh, I'm having to put out this fire. I'm actually at a hospital that's thinking long term, that's done some of that action planning that Wade and Eric were talking about in the previous session, right? That they're actually thinking forward, they're having this abundance mindset of what do we need for our community and let's go ahead and build it together. So it really builds that confidence that I'm joining an organization that has some steady footing, that has steady footing, and is thinking about the future and really engaging with the community about what they need. On top of that, credentialing and onboarding goes so much faster, which means when the provider finally starts, you've already got all your ducks in a row and you can stick to that minimum 90-day window for actually getting credentialing done, which means you get paid faster for the services that the provider actually does, which is important for your overall success and financial planning. With that, you can actually set up a provider that you are currently recruiting with an onboarding buddy or potentially some sort of rural mentor. If you're getting somebody who's right out of training, who's going to need to know that they have somebody to rely upon because they don't know everything yet. They've had to deal with maybe 3 snake bites ever in their training, and it's a regular occurrence in the summertime at your hospital, and they're going to need to be able to know who can they talk to about that. If they're going into an organization that is planning for succession planning, then they know that they're going to have a more senior physician or more senior APP that they can rely on, learn from, train with, as opposed to I'm coming in and I don't know who to talk to. And I immediately feel overwhelmed and maybe rural is not for me, right? So being able to do that, you're creating a relationship with providers who you're automatically already going to have more stickiness with than if you're doing reactive planning, right? And you're just, oh, I lost a provider, I better start recruiting for a new one and having that kind of gap in care. So you're able to have this smooth, and so from the organization standpoint, there's this smoother transition. I know some people think of it as costing money to have providers overlap, but really having somebody who's retiring in the next 2 years to be able to help train, hand over a patient panel, engage with a new provider, even if it seems like duplicative work for a period of time, it makes the patients feel very confident in the new provider. It allows that provider is properly trained into what's the culture you want from this organization, assuming the retiring provider was culturally aligned, right? It actually reduces turnover with the staff in the clinic that are doing the support staff or your OR staff or your ED staff because they get to know the provider in a way and get confidence in their skills. And then it really makes sure that you're really thinking from that long-term growth planning aspect, right? The board knows what's going on. The community knows what's going on. You're not creating uncertainty in the community as to whether or not, oh, we don't know what's happening with this specialty, or when this provider retires, are we going to have a cardiology anymore? Are we going to continue to have this service? Are we going to have orthopedics? Am I going to have to drive somewhere else to be able to get this service. When you're doing this long-term planning and you're out in the community showing, hey, by the way, here's the people who are coming in, and you're starting to market them. They won't be here for 2 more years, but here's who's coming. The community has a strong sense of confidence in the hospital. So a perfect example about that is this case study that we have. It's a Midwest Soul Community Hospital that we have worked with, right? And they had some senior leadership change, which oftentimes, right, that's what triggers some of these conversations. Is we have new senior leadership in the organization, and they were looking at this of, all right, the independent practice in the community had a lot of aging providers. They're retiring out, and we really need to start rebuilding a new primary care base. There hasn't been a focus on it. We have been relying entirely on the independent practice for such a long time that we haven't built any primary care from the hospital standpoint. And the independent group didn't really, they're like, well, we'll support anybody that you do, but we weren't planning on continuing the practice, right? We were planning, we'll probably sell you the practice at some point. And so looking at the need for primary care and for the market expansion, they really had to think, okay, not everybody in the independent practice is going to retire it all at once. How many people do we need long term? How is our community growing? How is it changing? What are the business opportunities? Working with the department, like the economics department, with the city council, understanding, okay, what new businesses are coming? What is the growth plan for the city itself and the town itself, so that we can make sure we can have enough primary care to service this? Knowing we can't recruit 5 primary care providers all at once. That's too expensive. And then they'd be sitting there not doing anything for how many years, right? Like the ramp up would be incredibly slow. So it needed to be phased in appropriately. So what the CEO did was actually reach out to residency programs for providers who were, in their second and third year of residency, inviting them to the community and having them come and do regular visits and meet the independent providers, but also meet the community, so that they could get their minds wrapped around, is this someplace I want to live? Is this someplace I want to relocate to? And in doing that, the CEO was actually able to contract with 4 primary care physicians that are actually graduating or finishing their residency programs in a sequence where he knows that he's going to have 2 new providers in 2-year period to properly actually align with the independent practice and allow them to start getting trained up. Those 2 providers will be able to be trained by retiring independents. The 2 independents will be retiring, or 2 of the independents will be retiring about by year 3. So then those people will have a year of training under those independents, as 2 other primary care physicians will be finishing up their residency programs and will also be able to join. So he's addressed the ramp up period. He's addressed the succession planning. He's addressed the transitioning of patients, and he's also able to do it in a very financially smart way with regards to the cash outlay for the organization. And it times up really well with the state's student loan repayment programs, right? And being able to support that. So, I mean, just a fantastic case study of how that proactive thinking and reaching out to residency programs to have, really start training rural providers for your specific community, not just rural healthcare overall, but for the community that you're in, and giving them a confidence that they're going to come and they're going to stay. So let's also talk a little bit about what happens from an operational standpoint when we think about it from a provider recruitment plan and a provider strategy. So Claire discussed a little bit of, like, when you're looking at the productivity information and you're looking at this, okay, recruiting providers is expensive. We don't just have buckets of money and a CFO being with a printing press to just being able to get me whatever provider I want to be able to get. So sometimes we identify, and looking in that productivity, hey, you need to recruit for this, but if you do some operational improvement and address some of the pain points that these providers are having, you could probably buy yourself some time and recruit in 3 years or 4 years rather than today, because you can address some of your patient wait times right now by looking at what's going on with your patient throughput. What are the things that are actually creating barriers? And you can collaborate with those providers on those operational needs. And so you include them in those discussions of saying, hey, we engage with you on our provider strategy. You recognize that, hey, we definitely need more of these types of providers, but it's going to take time to get there. So what do we need to do together right now? What are the staffing levels that we need? What are the support staff? What are creating barriers for you to have the patient throughput that you need to have, right, as a provider? So are you currently seeing 14 patients today? What would it take for you to see 16 or 17 patients per day? Because realistically, with our wait times, that those are the numbers that we need to be hitting for this specific clinic, right? One of the things that actually comes up that actually creates a lot of providers to leave an organization is underestimating what the actual call burden is. They didn't realize, oh my goodness, what it's like to be on a 1 and 2 call schedule, because they didn't experience that in residency programs, right? Rarely do they have that kind of rural call burden. So meeting with the providers and understanding, okay, hey, I can't recruit another provider to get us to a 1 and 3 rotation. What do I need to work with you operationally on to make the call burden more reasonable? Is it utilizing an APP as first call versus the physician as first call, and you being more backup call? Would that reduce the call burden? Are there operational things we can change about this to address your pain points? Keep a provider, instead of a provider just leaving unexpectedly, and then you find out in their exit interview, like, I couldn't handle the call burden. It was just too much. And so now you're stuck. Okay, now I'm on a 1 and 1 rotation, and I'm probably going to lose this provider if I can't address this issue. So engaging with providers on a regular basis of what's realistic about what you can recruit in versus not is something that's going to be really important to make sure those providers have that kind of voice. Um, Moving on to the next slide with regards to operational pieces, right? Another thing is providers, we know that providers are expensive and we have to be able to compensate them fairly. It gives providers a degree of confidence when you can say, hey, here's our recruitment plan, and here's what is the business case behind that. Here's the volume that we expect this new provider will be able to see. How quickly will they be able to see it in? And so you're able to give them a pro forma that supports their compensation, rather than guaranteeing them some sort of compensation that you don't know after 2 years, is that still going to be reasonable to pay them? So you can set those realistic expectations, but you can also, for your current providers, you can actually really support them of understanding, hey, how is your compensation going to be impacted if you're on a productivity model? If we recruit a new provider in, do we have the volume and market to actually support multiple of you, or are we planning for outreach clinics? How are we going to be able to do this? So really engaging with your providers on this and having good transparency is going to be really key for having this provider strategy be successful, but also utilizing that strategy to really engage with providers. With that, let's go ahead and Claire, go to, I think we have another poll question before we get into how we utilize telehealth with our provider strategy. So before I talk a little bit about telehealth and this provider strategy, I want to know who's using it. So who is using telehealth? Are you using it very effectively? Yes, we have it, but we're limited to just a few specialties. No, but we're very interested in using telehealth in our provider strategy, versus nope, we do not use it. And I know that there are some of you who might be saying, no, we do not use it, but used to use it during the pandemic and said never again. Because some organizations had mixed experiences when you did it on the fly all of a sudden as a point of necessity. So I'll give this a few more seconds. All right, so it looks like about 60% of you guys are using telehealth in some sort of capacity, but it's in a very limited basis, versus 16% are using it and feel like you're using it very effectively. And then still 16% are nope, but we're interested, and very few saying nope, we're not using it at all. So good to know with where you guys are in telehealth. So let's talk about how we think about telehealth from our overall provider strategy. So one of the things, telehealth is a good way of an entry pool into, should we expand into this service? Is this something that we can provide? We don't have the volume to justify hiring somebody or even having somebody coming in multiple days per week for it. So is telehealth a potential option? You think about it now, we are having more and more providers who are looking for flexibility, whether they're providers who want to be part-time, want to work remotely, or they're actually somebody who's interested in retiring. That's an entire pool of providers that a lot of people are overlooking as to be able to recruit them, because they're like, I don't have those kinds of options available. And being able to have telehealth options for those providers actually really expands that recruitment pool. And it may be a simple, there's a hospital that we have worked with in Nebraska that has done a great job of saying, okay, this provider's family is going to continue to be based in a more urban area. They're going to do telehealth for 2 weeks and then come on site for 1 week and do that as a rotation so that their patients are getting access to this provider. They're being able to use them for consults. The provider, this is somebody who just realistically with their family cannot move to the area at this time. They may be able to in the future, but telehealth was a way to actually get a specialty that they didn't know whether or not they could actually ever get full time, at least without building it up. Right. Now, this is a perfect example of now a provider has the ability to have work-life balance because he actually gets to see his family for the majority of the month, right? And then also think about I gave that example previously about the call burden. If a provider saying 1 and 2 call doesn't work for me, how do I address this? A telehealth of having telehealth for your night or your weekend coverage could for low acuity patients is something to really potentially consider for reducing that overall call burden for a provider so that you can actually operate on a 1 and 2 call rotation, which sometimes is very difficult. Another example is, especially I think most of us are familiar with telehealth for psychology, since we cannot get those behavioral health specialists in our communities. We've been able to use it a lot in the behavioral health space to be able to bridge that gap. But sometimes it's a matter of another specialty, especially the medical specialties, nephrology, endocrinology, where it's really difficult to have it, where your primary care provider can probably do most of the care management for that patient, but they need a specialist to meet with that patient once a month, right? So using telehealth to be able to bridge that gap is really important. Another piece is telehealth is a way that you can actually start working with a provider on their onboarding and ramping up and start building them a patient panel before they even get to the community. So once they start getting to the community, the patients are already familiar to them because they've been visiting with that provider remotely. It is important to pay attention to how telehealth is being reimbursed, especially post September when that current telehealth laws expire, and we'll see what happens with that. But it is a way to like actually get ahead of your provider strategy in a really financially smart way right now. So with that, I'm going to hand it back over to you, Claire, to close us out with regards to our provider strategy discussion.
Thanks, Opal. So great. Let's say you have a medical staff development plan in place or a provider strategy in place. How do you use it effectively? What are the first steps to really begin to implement it to make sure it doesn't just gather dust on the shelf and you'll have done all this work, but you can't really get any action to come out of it? So if you have a medical staff development plan, really the first steps for implementing it are along the same lines that you would do if you were developing a provider strategy. Number one is really clearly defining what specialties need to be recruited first. What are the specialties that need to be recruited in year 1 and year 2 versus year 3 and year 4? Where are there going to be the largest gaps in your current and future demand, and how quickly are those gaps going to occur? This could mean are people that you're doing succession plans for, are they retiring sooner rather than later? Understanding where those needs are is going to be really important right off the bat. You have to create that timeline for yourself to really set yourself up for success. Again, identifying critical roles at risk due to retirements. This also includes folks that are at high risk for turnover, folks that could be facing burnout. How do you get individuals in to help support them, to make them feel, like that they actually have support from your organization and then they're not at risk for burnout anymore? Understanding the budgetary impact of each recruit. So again, this gets back to now that you've got your timeline in place, how are you tying it to a compensation strategy? How are you tying it to organizational strategy? So it can be put into annual budgets each year. So you can plan effectively for, yes, here's your recruiting in year 1, year 2, year 3, and here's how the budget needs to adjust based on our planned recruitments. Making sure that you have appropriate onboarding and ramp up time and any other operational support that's available is also pretty crucial. So Opal talked about how you can have providers that come in. If you've got this effective recruitment plan in place, you can have providers that come in as a succession plan, but actually train with the person that's going to be retiring. And so they have a faster ramp up time and there's an easier transition in terms of patient panels. Understanding where access to care is most valuable and vulnerable. So understanding, again, Where are those specialties where you could experience a gap in care, and how do you make sure that doesn't happen? How do you maintain access to all of these specialties that you find so crucial to your organization, and how do you make sure that that's sustainable well into the future? An example of this would be if you had only 1 or 2 providers that were in one specialty and both of them were at risk of retirement. Having a succession plan in place for them is going to be really important to make sure you are maintaining access to that specialty in your community. And then the fifth really big point here is if you're an organization with multiple locations, making sure that certain locations are serving the right specialties and that they have the right amount of providers, and that you're sharing the right amount of providers with those locations, again, to create that comprehensive care within your organization. So those are really the first steps of a medical staff development plan. So how does that differ from the first steps of a provider strategy? Well, with a provider strategy, you would have done those steps already that we just outlined in the medical staff development plan. So you're starting really at the next phase where you're looking at, okay, we've got our estimated timeline in place. Let's launch into recruitment, retention, and alignment activities. We know what we need to do. Now let's go out and do it. You're able to act on those recruitments that you really want to do in year 1 and year 2. Because you have this process moving, you can then turn your attention to folks that are going to need longer lead times for recruitment. The folks that you're trying to recruit in years 2, 3, and 4 that may take 18 to 24 months to bring on, you can turn your attention to finding those individuals and start executing on those deliverables within your plan. Dotting the I's and crossing the T's, in terms of organizational strategy and how you're tying your provider strategy to your budget, making sure again that you're really tying those financial aspects of your strategy to the organization strategy. Again, holding your feet to the fire to drive these, it has to tie financially to your organizational strategy. Because you have this plan in place, because you have timed appropriately for recruitment, you can now turn your attention to some of the alignment challenges. If you have operational inefficiencies that have been identified in your provider strategy, you can now turn your attention to devote to breaking down some of those barriers. If you have issues with low productivity or with referrals from community providers, you can focus on problem solving for those and understanding where are their barriers, how do we break down some of those walls. You've got the other aspects of your plan moving. You can now turn your attention to this. And finally, Opal's touched on this a bit, but engaging with future talent. Having a provider strategy is such a beautiful tool when recruiting folks that are in training, talking to them about, hey, this is how we are planning for your specialty at our organization in the future. This is how we're planning to potentially bring you on. This would be your trajectory. All of those are really important and critical tools to have when you're recruiting folks that are still in training and can really fulfill your needs in years 3, 4, and 5. So a lot of questions that we typically get are, okay, we've got a provider strategy in place. We've got a medical staff development plan. We've identified these areas for alignment or operational improvements, but how do we engage with providers around these operational improvements? How do we start to have these conversations with providers and make sure we're all on the same page and they're really driving the solutions to these? And what we typically say is providers really need to be involved in this process from the beginning. They need to be involved with the development of a medical staff development plan or a provider strategy at the start. Those 5 different analyses that we've talked about and the data behind them, that needs to be shared with providers. It's an understanding to build trust of, hey, here's the 5 analyses that we did. Here's how, and the analyses and the data that we're using to make all of our strategic decisions off of this plan. This is the background that we're using. Give them time to provide feedback. Give them time to provide their input. One of the biggest things that we do when we're conducting medical staff development plans for folks is we'll interview different provider groups and we'll gather feedback from providers. They're the individuals that are boots on the ground seeing patients. They can identify where there's areas for improvement or operational inefficiencies. They know the specialties that are going to be needed in their area or additional specialties that they'd like to see. Those opinions are really important to include in your provider strategy.
And one thing,
Additionally,
Claire,
go for it.
I would add to that is saying One of the things that providers mentioned to us a lot is actually they're concerned, where are we going to put these providers, right? The space planning, like where's the room? Like I'm already working with just 2 patient exam rooms and you want to bring in somebody else, like where are they going to go? So that long-term planning, you could be like, guess what? We're going to build an MOB, or like we're going to acquire this space that we're going to fit out. And so you can actually talk to your providers who sometimes won't say that out loud
Mhm.
until like the last minute, that they're highly concerned about where's the staff going to come from? Am I going to lose an MA if you recruit somebody? Because where are they going to come from? You can actually show them all of this plan and engage with them and address those concerns that sometimes they don't voice right away.
Completely agree. And I think the other big thing we hear, and there's a lot of organizations kind of fall into this trap, is they'll take these opinions from providers, but there won't be a follow up with providers about how their opinion is incorporated into the end deliverable, right? There won't be a, hey, here's how we took the advice that you gave us and took the feedback that you gave us, and here's how we incorporated it into the provider strategy. It's really important to share your final provider strategy with providers, highlight the areas that you've worked on together, and highlight the solutions that you've come up with and how their recommendations have been included. These providers are super valuable. You want them to kind of have ownership and drive alignment issues. You want them to be on board in your boat, rowing in the same direction you are. So sharing that final deliverable with them and working through the rationale with them is so critical to really making this document actionable and having them engage with you around this. So I think we'd be somewhat naive to assume that all rural hospitals are independent. There are many of you out there that are rural organizations that are with an existing partner or are part of a larger system. So how do you engage with an existing partner around a medical staff development plan or a provider strategy? How do you bring them to the table to start having some of these conversations should you need support? Right off the bat, you want to begin with some quick wins to build that trust, to build that relationship. So start by focusing on achievable goals that have been established in your medical staff development plan and showing them how this decision making, how your data and strategy are driving these decisions and how they can be very effective. One of the biggest areas that we see helps bring system partners to the table is when you connect your strategic decisions to the financial impact of the system. So a couple examples of this, one would be, if you want to enhance alignment within primary care, and so you get more patients in the door with primary care, that's going to drive more higher acuity referrals to the system partner. That impacts the bottom line of that system partner. When you're implementing long-term recruitment strategies for those folks that take 18 to 24 months to recruit, that are recruited in years 3 and 4, you are reducing costly recruitment delays. You are maintaining access to care. You are doing all these things to limit high-end costs that could come if you don't do them. So again, showing them and educating folks on how that impacts their bottom line is super important. And finally, utilizing these strategies to support operational planning and ramp up time for new providers. Again, bringing new providers on board as a succession plan for retiring providers, but bringing them on board to be trained by the retiring providers and have the retiring providers transfer their patient panel, making that process smoother and making that ramp up time shorter, again, impacts the bottom line of the system. What we would say is that even the most sophisticated systems out there sometimes don't understand these concepts. So your ability to dictate these concepts and share and educate these with your system partner is super important. You have to be able to dictate your value as a rural affiliate to your system partner. Finally, being able to leverage the provider complement strategically. And so what we mean by this is identifying where there are areas that you may need your partner and where there are things that you can do on your own. An example of this is, okay, where can you utilize APPs instead of physicians? So if you're in a full practice state, where can those APPs be utilized rather than physician recruitments? Where is it better just to have part-time providers rather than full-time providers? Additionally, determining what specialties and services are really important to have at the rural affiliate versus ones that the partner can help you deliver. If they have people come 2 or 3 times a month in certain specialties, how can that drive future referrals to the system if you have a cardiologist come 2 or 3 times a month to see cardiology patients at the rural affiliate? Does that mean that they're going to get some higher acuity patients that are being transferred to the system? Again, that's value that the system might not see that you bring to the partnership. So an example that we have here is really how a system utilized their medical staff development plan really effectively. So we worked with this health system, and they own multiple critical access hospitals. They're a large tertiary referral center. And for over a decade now, I believe, they've used their medical staff development plan really effectively in a couple unique ways. The first way is they really use it to support getting J1 waivers approved. So your medical staff development plan, when you conduct it, it demonstrates community need, right? It demonstrates, hey, this is how many providers we need within these specialties within our community. So this organization, for example, say their community needs an ENT provider. They would go out and search for an ENT provider. And if in 1 year they didn't really have anyone biting and they couldn't find anybody, they would then expand the search for J1 applications, and they would use the medical staff development plan to support the J1 applications and waivers, again, leaning on and demonstrating the community need for that ENT provider. Another interesting way they use the medical staff development plan was to support providers who had high productivity, or, when you have a medical staff development plan, it's going to demonstrate shortages or accessibility issues in certain specialties. If you have a provider that's in that specialty that's on really high productivity, making sure you can document in fair market value and provide them appropriate compensation, that doesn't violate Stark or NT kickback compliance is really important. And that medical staff development plan can help you articulate and provide the rationale for that argument. Finally, they use the medical staff development plans by different specialties at different locations. They had a couple clinics that were on really the edge of their service area. And they use the medical staff development plan to leverage and understand, based on specialties, what providers were needed in each location. And if they needed additional providers in certain specialties at those locations, did that mean that they needed to recruit in their core market? So it created, again, a comprehensive plan that encompassed all locations that were part of the system. So that's if you're already part of a system partner. But what happens if you're an independent rural hospital, but are potentially looking to partner or don't know if you'll remain independent in the future? How does having a medical staff development plan or provider strategy set you up when it comes to potential partners? And our biggest, and what we say all the time, is that any strategy or plan as a rural organization that you are actively implementing only strengthens your negotiations when it comes to a potential partnership. And it does that for a couple of reasons. As an organization, if you understand what your community needs, what your provider supply is going to be now, what it needs to be in the future, and what your target provider complement is, and you could educate a potential partner on that and explain to them the rationale behind those needed recruitments via those 5 analyses that we did. And if you can show, hey, we've taken these recommendations and incorporated them into long-term planning and budgeting, this is all things that your potential partner doesn't have to invest money in and do for you. You've done this for them already, and you have the roadmap and rationale to prove why your community needs these services within these specialties. So again, it's showing a potential partner your value, demonstrating what you need and why you need it, again, only adds to strengthen your leverage in a negotiation and in a partnership. So I know we're approaching our time limit today, but wanted to give you 5 key takeaways. If you don't take anything away from this presentation that Opal and I have given, these are 5 key things. 1 is have a medical staff development plan and provider strategy in place and update it every 2 to 3 years. It's so useful for your organization. It can be utilized in so many different ways. It's so important. It helps understand your gaps in care. Make sure you know what specialties are going to be at risk in the next 4 or 5 years based on your provider need. Understand what's going on in these specialties and identify any vulnerabilities. Plan for long-term recruitment. Opal talked a lot about this, but being able to effectively plan for long-term recruitment and limit those gaps in care is so important down the line. And engage with your providers on the process. Bring them to the table, show them you value their opinion, and incorporate their opinion into the final deliverable. And make sure the medical staff development plan or provider strategy supports organizational strategy. Tie it to the organization, tie it to the bottom line of the system, make sure it can be implemented, and make sure that you have folks that are holding your feet to the fire to follow through on the goals outlined in your provider strategy. And with that, thank you for your time today.
Hey, thank you very much, Claire and Opal, for just closing out this year's conference with, a discussion on looking at that future perspective and having a 5-year strategy for it. And for those that are in the audience, I just, as we wrap up this conference, on behalf of all of us at Stroudwater Associates, thank you, thank you, thank you so much for spending time with us, both this week and if you were here 2 weeks ago for that. Whether you joined us for a single session or participated the entire series, we are grateful for your engagement, your thoughtful questions, and most importantly, your ongoing commitment to rural healthcare. This conference was designed to share practical strategies, real world examples, and data driven tools to help rural and community hospitals navigate today's challenges and plan for tomorrow's opportunities. We hope you are leaving with new ideas, deeper insights, and actionable steps you can take back to your teams. We also greatly appreciate your feedback. A post-brief event survey will be sent to you shortly, and your input will help us continue to shape programming that is relevant, timely, and responsive to your needs. Thank you, thank you, thank you again for the work that you do every day to keep care local. We are proud to be your partner, and we look forward to continuing the conversation in the months ahead. Thank you, and have a great day.